Wow. After an introduction like that, makes you feel like you should run for office. I'm John Goodman. I approve that message. Wrong? All right, different mic. I noticed this is a sold-out audience here today. That's kind of impressive. I think it probably has a lot to do with the invitation that Tina sent out. I thought our office was being a little bit generous when we suggested some of those remarks, but I enjoyed reading every word of it. Now, I'm going to guess that a lot of you think I'm a Republican because PBS just virtually said I was a Republican. And some of you see me at Republican fundraisers. And I was very active in talking to Republicans last year during the election. Dallas is the best city for a Republican candidate to come to raise money. So candidates don't come here to talk to me. They come here to raise money, but when they have some downtime, a lot of times they do want to talk to me. And I did advise the top policy person for the 3 Republican candidates for president last year. So that would have been Trump, Nikki Haley, and DeSantis. You're not supposed to do that, by the way. But the Republicans were so desperate for help that I decided I'd violate the rules. What we have in Congress, having said all that, let me say that the greatest obstacle to rational health policy in this country is partisanship. And both parties are guilty. And it goes all the way back to Hillary Clinton with her health plan, which I guess was before some of you were born, maybe. So what the parties do is they develop a health plan of their own without any input from the other party. Then they put a bill on the floor, and nobody from the other party is going to vote for it. So then to get over the finish line, they have to go to the special interests, and who are they? Well, the people who spend the most money on healthcare lobbying in Washington are the hospitals, the drug companies, and the insurance companies. And to get their help, of course, they want some changes which are good for them. And what we end up with is bad policy. And it's policy that puts billions of dollars into the pockets of those special interests and has almost no impact on the health of the American people. And we're continuing that even now. So with the Republicans, who are just as bad as the Democrats, with George Bush gave us Medicare Part D. Right now we're spending $150 billion a year on that program. It has increased drug consumption among the elderly by about 7%. So what we're spending is way beyond the problem that we're trying to solve. With the Democrats, we have Obamacare. Same thing, a very poorly designed program, pushed through by special interests who are making billions of dollars off of it. Then you had Hillary Clinton with her plan, same attempt. Then Paul Ryan. Those 2 attempts didn't work, but it's the 2 parties not talking to each other, and we're continuing that through this past year. This entire past year has been a health care year. And for the first 6 months, the only thing Congress talked about was Medicaid. And the second 6 months, about all they talked about was the Obamacare subsidies. And the 2 parties rarely talked to each other about any of this. Now, just so I get the lay of the land here, how many of you think that Medicaid is a really good insurance plan? I think that was a 0. Let me ask this. How many of you think that it's at least possible to reform Medicaid so it's actually better for people who are in it and save money for taxpayers at the same time? How many of you think that's possible? Okay. This proves that all of you are smarter than the whole U.S. Congress. Okay, what's wrong with Medicaid? First thing is that it doesn't improve anyone's health. And how do I know that? Because we had a randomized controlled trial out in Oregon, first time this has ever been done. People are selected by lottery. Some went into Medicaid, some stayed uninsured. 2 years down the road, they compared the 2 groups. There was no difference in their health. Now, one way to understand that is to understand that people who are uninsured get 80% of the health care as people who have insurance. And if they get a bill they can't afford, they just don't pay it. So that's part of the answer to that puzzling outcome. But bottom line is, going into Medicaid doesn't improve people's health. It also doesn't get people out of the emergency room. You might think that it would, but in fact, when people enrolled in Medicaid, their trips to the emergency room increased by 40%. So they go to the emergency room more often if they have a Medicaid card. So here in Dallas, our safety net hospital is Parkland, and Parkland tells you online that the average in and out time in their ER is almost 6 hours. Yeah. So that's 6 hours. Most of these people are hourly, so they lose a day's pay, sitting around most of the day with sick people around them. And if the studies are accurate, most people that go to emergency rooms these days don't need to be there. They could have gone to a minute clinic, an urgent care clinic, or a doctor's office. And it's very expensive for taxpayers when these folks go to the emergency room, because the cost of that compared to the market price of the minute clinic or the urgent care clinic or a doctor's fee, all those are lower. And that's because in the emergency room, you're paying part of the cost of the MRI scanner and all the other equipment that they have. So if there were a way to get people out of the emergency room and to the places where all of you go for your health care, we'd save taxpayers dollars and we would improve the quality of care that people get. Now, another thing that's wrong with Medicaid is the people who are in it don't care for it very much. And what do they do? One of the things they did in the Oregon experiment is they tried to figure out how much people valued their Medicaid enrollment. So if you ask people to sell their Medicaid plan, what would they sell it for? Turns out it's about 20 cents to 50 cents on the dollar. In other words, they would sell their Medicaid plan for as little as 1/5 of what it really costs. And that also came out of the Oregon experiment. So people don't value it. They're not getting better health care. The quality does not increase. And so what is Congress going to do about it? Well, nothing. All the Republicans want to do is cut spending, and all the Democrats want to do is keep the spending where it was. There was no interest in reform. Or to be a little bit more accurate, when anybody got interested in reform, the hospitals were right there to say, we don't like anything John Goodman is talking about. We like our emergency room. We make money on our emergency room. Ted Cruz's health guy told me last spring, the hospitals come by their office every week. So then I said, well, how often do you see an enrollee in Medicaid? And the answer is never. And that's the kind of feedback our politicians are getting on an issue like that. Okay, so what could we do? Well, we had a whole bunch of suggestions, but here are the top three. Let people on Medicaid buy health care the way they buy food. So the other day I was at Tom Thumb down the street here, and there was a woman with an EBT card, which is food stamps. And the cashier said, well, there's not enough money on this EBT card. So she pulled out her billfold and pulled out a private credit card and paid the balance with that. What impressed me was how many private credit cards she had, considering she's on food stamps. We don't allow people to do what she did in healthcare. So if she went to a minute clinic, let's say she had an earache, and I'm just going to make up some numbers. Let's say the minute clinic charges $70, and Medicaid only pays $35. So she says, well, here's my Medicaid card, and here's $35 in cash. If the nurse accepts the cash, she can go to prison. So not only do we not allow sensible transactions in healthcare, we criminalize them. So our first recommendation is let's change that. Let's let them leave the emergency room, go to the minute clinic, pay market prices, whatever they are. If they were paying market prices, they could see any doctor in Dallas. Right now, I'm going to guess at least a third of the doctors in our city are not taking any new Medicaid patients. But if they paid the doctor's regular fee, they could see that doctor, and if they could top up their health insurance, whatever Medicaid pays, they would have access to everybody you all have access to. So reform number 2, let them have a health savings account, and I call these Roth accounts. And the way they would work is the managed care company would put money in an account. And the reason I use managed care company, here's something a lot of people don't realize. The left complains that Medicare Advantage is privatizing Medicare, right? They never talk about what we're doing in Medicaid. But even in the blue states, 2/3 of all the Medicaid patients are in a private plan. Now, these are terribly regulated, but they're run by private companies called Medicare contractors. So the way the health savings account would work is the Medicaid contractor would put money into an account, let's say, to pay for all primary care. And the enrollee would have to agree. But if the money was in their account and they pay market prices, they would do what all of us would do. They'd be sensitive to prices, and they would try to save money because at the end of the year they would get to keep it. And the reason I call it a Roth account is at the end of the year they would take it out with no taxes and no penalties, and every dollar they save would be $1 of income to them. And I would guess that we would cut Medicaid spending by 1/3 if we could allow people to do this. So we'd spend less on health care, have higher quality, and make people better off and lower the cost to the taxpayer. That got very little attention in Congress, but the 3 ideas I just told you, Newt Gingrich liked them, Karl Rove liked them, Steve Moore, Steve Forbes, so Senator Cruz. So a lot of people that you all know like these ideas, but we did not have success in Congress because the special interests opposed them all. Now, second half of the year, we're talking about the Obamacare exchange, subsidies there. Just a quick overview. When we passed Obamacare, that was subsidized, and the subsidy depended on your income. And when you got up to 400% of poverty, the subsidies ended. So everybody who makes more than 400% of poverty got no subsidy from the federal government. What is 400% of poverty? Well, it's about $62,000 for an individual and twice that for a family. So once you get above that, you're on your own. You pay market prices. What are we talking about? What does Obamacare cost if you don't get a subsidy? Well, if you add together the average deductible and the average premium across the United States, it comes to about $25,000 a year for a family of 4. So you could have a low-priced Tesla for that amount, and you could have one every year. And so what was happening was that people who weren't getting a subsidy were dropping out. And the non-subsidized part of the market was headed toward what I call a death spiral. Now, what death spiral means is the price gets so high that the healthy people begin to leave. And when the healthy people leave, the remaining people are sicker, therefore more expensive, therefore the insurance company has to raise its premium. And once it does that, the not quite so healthy people also leave. And then we go through another round of another increase. And this is what's called a spiral, and it keeps going until the whole plan collapses. Now, we got a second set of premiums to deal with this during the COVID era. And if you listen to the Democrats, this was because of COVID. In fact, sometimes they're called COVID era subsidies. But even so, that's not really why we got the subsidies. We got the subsidies because the Democrats didn't want their health reform to fall into a death spiral. Okay, so what's wrong? By the way, when I use the term Obamacare insurance, I'm talking about the insurance that you buy on your own in Dallas, Texas. You don't get it from an employer. You don't get it from government. Sometimes it's called the individual market. So, but you're on your own. And if the Democrats had their way, the only insurance you would be able to buy would be Obamacare compliant insurance. And when Obama was president, when Biden was president, they tried very hard to prevent any other alternatives. But that is their approach to this market. And so what we have is a market where people have no alternatives. It's very expensive. And here are the problems with this entire Obamacare ACA insurance. Number one, the costs are growing exponentially. From the beginning, the cost of these plans has increased twice as fast as premiums in employer plans. Today, the deductible in these plans is twice what it is for an employer. The out-of-pocket exposure is twice what it is in an employer plan. And this year, the out-of-pocket exposure in a typical Obamacare plan is $10,600 for an individual and twice that for a family. So that means if you were in a family, let's say you had 2 children with birth defects, you could actually pay more than $20,000 a year in health expenses before you got any benefit from your health plan. So that is obviously not going to be attractive to most families. So that's what put this system in a crisis, and that's why the Democrats came along. And the new set of premiums, they're called enhanced premiums, are very, very generous. So generous that 60% of all the people in this market right now face a 0 premium. They get health insurance for free. 80% are paying $10 or less a month for their insurance. So we're virtually giving away to most people. And by the way, it's when you give away something for free, you really invite fraud. So if I were an insurance agent trying to get you to enroll in an Obamacare plan, if you don't have to give me a check, then I can go away, write your name down, send it in, and put you in the plan when you don't even know I've done that. And I get my commission. And the evidence is that that's happened to millions of times. Okay, so we have increasing costs, not under control. And the reason they're not under control is because no one has an incentive to control costs. So if you're in an Obamacare plan, your subsidy is a percent of your income. And it's roughly, for higher income people, 8.5% of your income. So that's a fixed dollar amount. Now, you have no incentive to choose a less expensive plan rather than a more expensive one, because you're not paying the additional costs the taxpayers are. So on the buyer side, we have no reason to be price sensitive, no reason to care what anything costs, and it's almost as bad on the seller side. For the insurance companies, their profit is restricted to 15% of the total sales. The higher the premium, the more their profit. So we have a market where no one has normal incentives to control costs, and so they're not being controlled. So the costs are going through the roof. And by the way, everybody knows this. There have been very few hearings in Congress about it, but it's inconceivable to me that the average member of Congress didn't know this is going on. They come back, they talk to their constituents. So increasing costs, very, very narrow networks. Right now you can't buy individual insurance in Dallas that gets you into UT Southwestern over there, one of the best medical centers in the whole world. And they don't take Blue Cross, Blue Shield, exchange insurance. I was over there the other day, and there's a big sign that said, "We don't take that kind of insurance." You can't go to Baylor Medical Center. Down in Houston, you can't go to MD Anderson Cancer Center. Mayo Clinic, Cleveland Clinic, all over the country, the best medical centers, best doctors are not taking what I'm calling Obamacare insurance. They treat it like Medicaid managed care. The fees are really low. And after you perform the procedure, the insurance company wants to come back and argue over it. And UT Southwestern over here says that's not worth it for us. So your access to high quality care is closed off. You're paying through the roof for the coverage. And here's something else that you may find very interesting. Americans are not getting more health care. Now, I'm an economist, and first thing you learn in Econ 101 is there's supply and demand. The demand curve goes like this, and the supply curve goes like that. And even if you never had a course in economics, all of you know that in any market you have buyers and you have sellers. And intuition should tell you that no matter how much money you throw into the demand side of the market, people are not going to get more of the product if you don't do anything about supply. And one of the most surprising things to me about the whole debate going all the way back to Medicare and Medicaid, we're spending billions of dollars on these programs. And there were arguments for it and there were arguments against it, but almost no one in the public press asked, how are we going to get any more health care if we don't have more doctors, we don't have more hospital beds, we don't have more hospital procedures, we're just spending more money. And that's what happened. There was no increase in care. Now there was some shifting of who got care. And seniors got more care, low-income people got more care, the people in between got somewhat less, but no overall change in what was being done. Now, under Obamacare, we have the same thing. We're throwing billions of dollars. I would say both parts of Obamacare, the Medicaid and the subsidies, that's about $250 billion a year. Additional spending. But the number of doctor visits per person over the last decade has actually gone down. Hospital procedures have gone down. Our healthcare outcomes have gone down. Life expectancy has gone down. So we're spending an enormous amount of money, and it's not clear what we're getting in return. And then the final thing that I think is the worst thing about not only Obamacare, but our entire healthcare system, and I'm the only person who says this. If you go to the library and check out a book on health economics, if it's not my book, you're not going to hear what I'm about to tell you. And what I'm about to tell you is that in our healthcare system, no one wants a sick person. No employer, no commercial insurer, no Obamacare insurer, and no government program, if you want to know the real truth. Sick people cost money. Healthy people don't cost anything. And the sick people are not paying actuarially fair premiums that reflect their expected costs, and no one's paying it for them. The one exception is Medicare Advantage, which if we have some time, we'll talk about that. But this is a system in which all the insurers, all the health plans, including all the employers, have an incentive to attract the healthy and avoid the sick. And the way I know that is I just look at the way the plans are organized. The typical employer plan has free preventive care, maybe a free gym membership, other things that healthy people like. But if you go in the hospital, you can pay thousands of dollars. That's a typical employer plan. And what that says to me is they want to attract the healthy, and they do not want to attract the sick. Same thing true in Obamacare, much worse in Obamacare. And that's been true in Medicare. It's from the very beginning. Those programs were organized so that we over-provide to the healthy and under-provide to the sick. Now, this isn't just a feature of our healthcare system. It's worse in Canada. It's worse in Britain. Because if you're in a country with socialized medicine, you're the Minister of Health, it won't take you long to realize that 5% of the voters are consuming half of your healthcare dollars. And in a democracy, it's real hard to spend half your money on 5% of the voters, some of whom may die before the next election, some of whom will be too sick to get to the polls, and so they don't do it. So if you lived in Canada or in Britain, you would find it easier to, if you needed a Band-Aid, you'd find it easier to see a doctor in those countries than in the United States. But if you have the potential for cancer and you need an MRI scan, you are much, much better off in the United States than in either one of those two countries. So this is the biggest problem, in my opinion, with healthcare systems throughout the developed world. It's never talked about by other health economists, but I talk about it because I think it's something we have to address. Again, I think Medicare Advantage does address it quite well, but there you go. All right, so what is Congress going to do about the exchange? Nothing. The Democrats want to keep spending where it is. The Republicans want some minor reforms. Ron Paul the other day called them Obamacare Light, which is okay. But the kind of serious reform that's needed is not being proposed in Congress. So what can be done? Well, President Trump came out the other day and he said, let's give the money to the people and not to the insurance companies. And Pete Sessions and I agreed with him. We had an article in The Hill about this. Trump didn't say how it would work, but Pete and I have talked in detail about how it would work, and he's got a bill. I helped Pete and Senator Cassidy some time back with a bill that they introduced, and a lot of those same ideas are in our new bill. But the main thing that Trump mentioned, and the main and most important thing about the Goodman Sessions approach, is you let people buy the insurance that they want to buy that meets their needs. Now, there's an economist named John Gruber who's at MIT, and he is sometimes called the father of Obamacare. Nice guy, but just often wrong. But the other day he was talking to The Atlantic, and he said, here's my political philosophy. If the market can meet needs, then government ought to get out of the way and let the market work. The only reason to have government is if there are needs that the market doesn't meet. And I couldn't agree more. I just don't see why John Gruber can't see the obvious implications of what he's saying. Pete Sessions and I propose to let people buy insurance that meets their needs, as long as it's credible insurance. And that would be insurance that is not Obamacare compliant. Now, the most obvious place to look is what is called the short-term market. And that's a term that probably most of you are not familiar with, but it's been around for a long time. Short-term insurance used to last about 12 months. It was for kids going from home to school, going from school to a job, going from job to job. It's been around forever, and the nice thing about it is it's not regulated by Obamacare. None of the regulations that apply to other kinds of insurance apply to this insurance. It's also not regulated by state law, or it's very little regulated. So this is the closest thing there is to free market insurance. And right now it looks very conventional. It looks like the kind of Blue Cross plans that you would see before there was Obamacare. But a lot has been changing in the healthcare world. We have telemedicine, we have AI, we have all kinds of new products out there that have the potential to totally change the way healthcare is administered. And I would expect insurance to reflect that if it has the freedom to do so. So we're going to allow people to go into this market and buy insurance which meets their needs. Now, what do Democrats have to say about this idea? Well, they say this is junk insurance. I mean, what happens if you buy a plan that doesn't cover alcohol and drug dependence because you don't think anybody in your family has a problem? And then 6 months down the road, you learn that you were wrong and that you do have a problem. And so Pete and I have an answer to that. If you buy a plan and you have a medical need not covered by that plan, but that is covered in the Obamacare exchange, you ought to be able to go over to the exchange and buy a silver plan. So we would have people have access to both markets. And if their health condition changed, they could go to either market. And we think that solves the problem of junk insurance. Now let me just ask out of curiosity, how many of you remember Jimmy Kimmel's Baby? Anybody? A few of you, all right. So I never watched Jimmy Kimmel because I'm asleep before he comes on. But sometime back, he had Bill Cassidy on his show. Bill is right now head of the Senate committee that handles health care. And he and I have been friends for a long time. So there is Bill Cassidy, and Jimmy Kimmel said, well, would the Republican health care plan cover my child? And Cassidy said, well, yes, of course. And then later, Kimmel came back and said, no, Cassidy's lying, it wouldn't. And they went back and forth. But we never quite learned, I don't think it was ever made public, what the problem was with Jimmy Kimmel's child. But most of us assumed that we're probably talking about $1 million of medical expenses. And that can happen, and it does happen. So the question is, what do we think about that? Now, here's what everybody needs to understand. The fast food workers around the country would never, with their own money, buy a policy that covered $1 million of medical expenses. They are not going to do it. And why? Well, one reason is they don't have $1 million to protect. So, well, that's like buying $1 million of casualty insurance for your house, but your house is only worth $100,000. Okay, so there's no assets to protect. Plus, they know that if their child had serious medical expenses of the type we're talking about, the hospital's not going to throw the child out on the sidewalk. The hospital is going to take care of the needs. So fast food workers don't have an incentive to buy this kind of insurance, and they won't. How do we know that they won't? Because we learned this in the first year of Obamacare. So McDonald's, Burger King, these companies were required to offer Obamacare insurance to their employees, and they could charge 9.6% of wages, and that was the most. They had out-of-pocket costs, I think, of $6,000 or $7,000, and they could do that. And the employee had to accept that if they wanted to join the plan. And this is interesting. There is, if the employee wanted to insure his rest of his family, his wife and kids, he had to pay the full price. So when this was offered to fast food workers across the country, remember, these are young people, they're healthy. 95% of them turned it down, not just for their dependents, but for themselves. That's not the kind of insurance they want. So what do they do want? They want what I call limited benefit insurance, like the first $25,000, the first $50,000 of medical costs. They want to know if they get up in the middle of the night and go to the emergency room that they'll be able to pay for the care. They don't have to worry about it. They are never going to be thinking about $1 million medical bill because it's going to have no part of their life. And by the way, the probability of $1 million medical bill is really, really low. So it's rarely going to happen. So in my view of the world, I agree with John Gruber that the purpose of government is to fulfill needs that the market doesn't fulfill. So that's where you need a safety net. And we ought to let the workers buy insurance that meets their needs, and if their needs are being unmet, then let's have a safety net to do that. How am I doing on time? Okay.
You're fine.
All right. So let's, if I can, talk about the healthcare system in general. We covered Congress. Well, I want to ask you one question, back on Congress for a minute. Do you all know about the Yakuza? Anybody ever heard of them? These folks, if you're a member of their gang and you commit a serious error, you're required to sever one of your fingers. And then you have to offer your finger to your superior by way of atonement. Kind of gruesome, I agree. And so I've often thought that if members of our Congress had as much honor as the Japanese mafia, there'd be a lot less finger pointing in Washington. I have my cell phone with me when I do things like this because you never know, you could have an important call. No, the real reason I have it is because I want to make a point. If something goes wrong with my cell phone, I can pop over to the mall over here, and the Apple store will give me, probably they'll repair it when I arrive. They may have me make an appointment for later that day, but I have no trouble getting low-cost, high-quality repairs for my phone, and I wouldn't just have to go to the Apple store, I could go to many other places. But if something happens to me, the average time it takes Americans to see a new doctor in this country is 3.5 weeks. Think about that, 3.5 weeks. In Boston, where you may remember that Mitt Romney at one time was governor, and they claimed that they had created universal coverage in Massachusetts before there was Obamacare. Well, in Boston right now, the wait to see a new doctor is 1.5 months. That's what they call universal coverage in Massachusetts. So my question is, why is the market so kind to my iPhone and so mean to me? And I believe the answer is that this iPhone is produced and repaired in a real market with real prices where entrepreneurs know they can make millions of dollars if they meet our needs. Whereas over in healthcare, we have so suppressed the market week after week, month after month, year after year, that none of us ever sees a real price for anything in healthcare. No patient, no doctor, no employer, no employee. We have so suppressed the market that we really don't have a market in healthcare. What we forget is that when you suppress the market, you increase the importance of non-market barriers to care. And we like to think that we're different from the Canadians. And I probably have contributed to that because I've written about all the things I don't like about the Canadian healthcare system. But the truth is, we're about 80% just like them. If you live in Canada and you go to a doctor, it's free. In the United States, it's almost free. Every time we spend $1 in a doctor's office in this country, only 10 cents is coming out of our own pocket. So 90 cents comes from a third party, an employer, insurance company, or the government. In both countries, we primarily pay for healthcare with time and not with money. And that's not generally understood or appreciated. There's something very burdensome about paying with time. But if you notice with the professionals, the lawyers, the accountants, the architects, what do you call that exterior area when you walk in the door? It's reception area, right? And what do you call it when you walk in the doctor's office? It's a waiting room. So implicitly, I think we all understand this. Now, again, you suppress the price system, you suppress the market, you raise the importance of non-market barriers to care. And what are they? Well, how long does it take you on the phone to get an appointment with a doctor? How many days, weeks, months before you can see him? How long, I'll come back to you. How long does it take you to get from where you are to the doctor's office and back again? And once you're there, how long do you have to wait before you get care? These are all non-market barriers to care. And there's a lot of evidence that the non-price barriers are a greater deterrent to getting care than the price the doctor charges. And this is not just true for all of you, this is true for low-income people. And I'll tell you very briefly about one test that showed this, although there have been a number. So for people on Medicaid, they slightly raise the out-of-pocket cost of a prescription. So it's going to money cost them more to get their drug. And then they measured how much drop-off there was. And then they raised the time price. And the way they did that was they said instead of getting a 90-day prescription with one visit, now you're only going to get 30 days. So to get the full 90, you have to make 3 trips to the pharmacy instead of 1. And then they measure what kind of drop-off they got from that. And the finding was that raising the time price of care is a greater barrier to getting care than the money price. What a lot of people who are not poor do not realize is that time is more of a scarce resource for poor people than money. It's easier for them to pay a money price than to pay a time price. And I may have said earlier, when people go down to Parkland and spend a day, they lose an hour's, they lose a day's pay. So imagine a woman who needs a blood test, and she doesn't have a car, low income, and there's a MinuteClinic across the street that could give her the blood test, but she's not paying with money at market prices. So what does she do? She gets on a bus, she goes to a station, she gets on another bus, gets to the hospital, waits there, gets the test done, then reverses the whole thing. So she spent a whole day just to get her blood test, and that costs her a day's pay. And how much better off she would be if she could just go across the street and have government pay some or even most of the cost at the MinuteClinic. So even low-income people would be a lot better off if we relied on the price system than by suppressing it and causing us to ration by waiting. In the United States today, there are about 42,000 people on food stamps, which we talked about earlier. And these people can go into any supermarket we go into. They pay the same price we pay. You never hear of a supermarket saying we're not taking any more food stamp customers. They all take them. The worst thing that happens is you might live in a low-income area and have to get on a bus and get a mile or two to get to the supermarket, but that's about it. Over in Medicaid, we have 90 million people on that program. Many of them are the same people. And what's the biggest problem they have? It's finding a doctor who wants to see them. So I was in Boston a year or so ago, and as I sometimes do, I ask the cab drivers, the female, how is healthcare working here in Boston for you? And she said, well, she was on the Boston Medicaid program, and she was having trouble finding a doctor who would see her. And she said, I had to go down a list of 20 doctors before I could find one who would see me. And I said, well, you're going through the yellow pages? And she said, no, I was going down the list that Medicaid gave me. So that, again, is what universal coverage looks like in Massachusetts. So, again, I would say let's let low-income people buy health care the way they buy food. Let them go to the Minute Clinic. There are about 2,000 walk-in clinics across the country, and give them access to that, and they'll get better care, quicker care, and higher quality care. So to reform all this, we need to free the patient in that way. We need to free the doctors. Doctors are the only professionals in our society who are not free to reprice and repackage what they offer to the market. So if you're a lawyer, accountant, some other professional, and market conditions change, technology changes, anything that changes, you can reprice, repackage what you're offering to your customers. Doctors cannot. There are 10,000 procedures that Medicare pays doctors to do, and if you're not on the list, you don't get paid. And if it is on the list, you do. That's a terrible way to pay any professional. It's hard for me to imagine anything worse. Because if you try to pay a lawyer or accountant or anybody that way, and you try to think, well, what are all the thousands of things I want this person to do, you're not going to think of everything. And in Medicare, until there was COVID, they forgot the telephone, and they forgot email, and they forgot Zoom, because none of this was on the list. And it took COVID to get the federal government to realize that there are a lot cheaper, easier, smarter ways for patients and doctors to communicate with each other. So we need to free the doctors, we need to free the patients, and we need to free the entrepreneurs. Now, one question I get a lot, can free markets work in healthcare? And my quick answer is they're the only thing that works in healthcare. That show me a healthcare market where there's no Blue Cross, no employer, no Medicare. It's probably a market that works pretty well. Now, just looking around the room, I'm going to guess a lot of you don't know a lot about cosmetic surgery. But just give it a year or two and you'll get interested. All right, here's a market where there's no Blue Cross, there's no Medicare, there's no employer. It's a real market. And over the last 20 years, the real price of cosmetic surgery has gone down, 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 even as the price of every other kind of surgery has gone up. You get price competition, you get quality competition, you can compare prices, and all kinds of technological change. Huge increases in volume. And it's a market that works. Same thing for LASIK surgery. Talking on the telephone, well, 20 years before there was COVID, we had a Dallas firm that made it possible for people to talk on the phone to their doctor. They have right now 20 million customers. It's Teladoc. And all this, again, is outside the normal third-party payer system. Rx.com came into existence to sell online drugs to people competing with a local pharmacy. Again, outside, this is for people paying with their own money, outside the insurance system. So my quick answer is that yes, the market works quite well if we allow it to work, and it'll work in healthcare.